Hello and welcome back to the PJ Pod, brought to you by the Pharmaceutical Journal, the Royal Pharmaceutical Society's official journal. I'm Killen, and in this learning episode, we'll be talking about the changing treatment landscape of chronic lymphocytic leukemia, or CLL, and the role that pharmacists can have in supporting patients. But first, I'd like to thank our sponsor, BeiGene UK, for funding this episode. BeiGene are a science-focused global biotherapeutics company committed to advancing 10 or more new molecules to the clinic each year. They conduct high-quality research with minimal excess costs, which enables cancer medicines to be affordable and accessible to patients in countries around the world. BeiGene UK have a commitment to partner in science and education, as well as delivery of world-class cancer medicines. The content of this episode has been independently created by the PJ. CLL is a type of cancer in which the bone marrow makes too many lymphocytes that don't work properly, meaning they're not as effective at playing their usual role in immune defense, leaving patients at higher risk of infection. While CLL is a relatively rare cancer, around 3,800 people in the UK are diagnosed each year, it is the most common type of leukemia, and the past few decades have seen rapid advances in therapeutics. So in today's episode, we meet two pharmacists involved in the care of patients with CLL to hear how pharmacists can best contribute to patient care, as well as Anthea Holland, who has been living with CLL for 17 years, and who talked me through the impact that this blood cancer has had on her life. And we'll start with Anthea, who began by telling me about her initial diagnosis.
Well, I was diagnosed with CLL back in 2007, and as with so many people, it was by chance on a blood test for something else because I'd had one or two abdominal issues. Although in retrospect, I had been having infections, sort of upper respiratory tract infections that dragged on. And he said, well, your blood tests have shown you've got CLL. Now, I think he used the abbreviation because I was a GP for 25 years, but I hadn't practiced for about 7 years, and I couldn't think what CLL was. It took me maybe up to a minute to realise what he was saying. Usually I'm sort of pretty quick in picking up abbreviations and things, but I think when you have a shock, your mind doesn't function in the same way. At that time, I don't think the term blood cancers was being used as it is now.
This type of misunderstanding isn't as rare as you might expect. Tejal Gorasia, Principal Pharmacist for Cancer Services at Milton Keynes University Hospital, reflected that even now, clearer communication could be needed when talking with CLL patients about their condition.
I guess part of it is that the sort of blood cancers aren't necessarily talked about as much. I think there was something, an article that I read, I think it was Blood Cancer UK, that a lot of blood cancer patients don't know that they've got a cancer. They're labelled with sort of old Latin names that maybe they don't understand. It could just be that they're not told that it's a cancer. And so it's kind of shielded a little bit from the publicity that maybe the solid tumours might have.
So there is a need for healthcare practitioners to communicate about this cancer more clearly. And whilst any cancer diagnosis comes as a nasty shock, the prognosis for CLL patients is often relatively promising. One reason for the increased life expectancy is the development of novel CLL treatments. Parbutt, who is a consultant pharmacist for cancer services at Leeds Teaching Hospitals NHS Trust, explained how the treatment of CLL has changed in recent years.
So as you'll know, we used old-fashioned chemotherapy for many years in this area, to both good effect for patients with normal cytogenetics and to poor effect for patients with 17p or p53 deletion who were very unresponsive to standard chemotherapy. And in the early years of 2010 kind of onwards, we first saw targeted therapies come into clinical trials for CLL. And over the last 10 years, they've completely changed the way that we treat CLL, such that we no longer use chemotherapy in this area virtually at all now.
This was especially significant as patients with 17p and TP53 mutations are found to have poorer prognoses. Catherine told me about some of these newer targeted therapies.
The first real changes came for our patients with the poor risk cytogenetics, where the targeted therapies, and ibrutinib was the first one, so a Bruton tyrosine kinase inhibitor that works on the B-cell signaling pathway, and that had the same response rates in both patients with normal and high-risk cytogenetics, which we'd never seen before. So suddenly we had a therapy that was offering good progression-free survival for our high-risk patients too. And initially, as with many novel agents, these came in for patients who had multiply relapsed disease after maybe 1 or 2 prior lines of chemotherapy. And then gradually they've worked their way forward in the treatment algorithms. Very quickly, they became frontline therapy for our high-risk patients. But initially, they were reserved for the relapse setting for our normal cytogenetic patients. But we've also then subsequently seen second and third generations of these drugs. We've seen acalabrutinib in the second generation. We've more recently had zanubrutinib in the third generation, and we have more of these agents in clinical trials. And these have largely now superseded chemotherapy, which has lost its place in our algorithm. We've also another very important targeted therapy in this area called venetoclax, which targets something called BCL2, B-cell lymphoma protein 2, which again is involved in that B-cell signaling pathway.
Tejal again brought up the importance of communication. She explained that because of how much treatment has changed in recent years, it's important to explain the treatment pathway to patients.
I think it's important to provide that information to the patients so that they can make a bit more of an informed decision, and they can understand why they've been given the treatment that they have, because they could be sitting next to in the day centre and next to another CLL patient who's been given a completely different treatment, and why that could be.
This changing landscape is certainly reflected in Anthea's experience so far. Having lived with CLL for so long, she explained that she's gone through many treatment options over the years.
And so the first treatment I went into, which was sort of under 3 years from diagnosis, was a trial of lenalidomide. And in fact, the trial was stopped within 3 months of me going into it because there was excess mortality in the treatment arm.
After the trial, Anthea managed to delay treatment for another 18 months.
Because I'd been in the trial, it meant that I was actually on second-line treatment. And so I was actually eligible for ibrutinib, which was at that time very new, and that worked very well. I was on it for about 2.5 years, but then I developed some numbness in my feet, and my hemato-oncologist at Barts thought this was a peripheral neuropathy, which he thought was due to the ibrutinib. And I was given 3 choices. One was to stay on the ibrutinib. The other one was to stop it for a bit and start it again. And the third one was to stop it and see what happened. So I opted to stop it. But it was quite nice, to think I could be drug-free and see what happened.
Anthea was drug-free for another 18 months, but then developed autoimmune hemolytic anemia, a decompensated acquired hemolysis caused by a person's immune system acting against its own red cell antigens.
So this time I was on to third-line treatment. And again, I was very lucky because venetoclax had just come into the picture. So, I was a very early recipient of it, I think. And I think at that time, and probably because it was third line, it was just monotherapy.
Unfortunately, Anthea had to stop venetoclax due to a suspected interaction with the COVID vaccination.
my platelet count dropped very low after I'd been on it for a couple of years, but it was within a couple of weeks of having the first Pfizer vaccine. And so the venetoclax was stopped because there was concern that it was actually due to the drug. But then it was recommended I had the second Pfizer vaccine because at that time there was no treatment for COVID. And it happened again, but more severely. So it was blamed on the COVID vaccine, and that it wasn't actually due to the drug, the targeted treatment. So then I was off treatment again for another 18 months when I relapsed quite badly, and again had hemolytic anemia. And so the venetoclax was restarted with rituximab about 20 months ago. But it never worked as well, and by this April I was very, very unwell, as I realised now I was seriously ill. My bone marrow was completely full, well over 90%, with CLL, and my hemoglobin had dropped down to 60, and I required an emergency blood transfusion. And so it was decided the one drug that was left really for me to try was zanubrutinib, and that's what I am on now.
Anthea's treatment journey highlights the sheer number of treatment options that patients may have to go through to find something that works for them. She also reflected on what the availability of targeted treatments has meant for her.
I feel I have been extremely fortunate, both in terms of when I developed the disease and, the amazing targeted treatments, that have appeared, and how cutting edge it is, because my current drug, zanubrutinib, I know it was only approved by NICE 6 months before I was able to have it. So I'm just really grateful and would obviously do anything to tell anybody, how good it is and how much the journey has changed for people.
Whilst the positive impact of these targeted CLL therapies can't be ignored, it's important to reflect on some of the challenges that these treatments pose, as there are significant drug interactions and side effect profiles that must be managed when using these treatments. We won't actually cover these here, because these challenges have been covered in depth in a previous episode of the PJ Pod called BTK Inhibitors, What Pharmacists Need to Know, which will be linked in the show notes for listeners wanting to find out more. Catherine told me that the advent of targeted treatments has created new opportunities for pharmacists to be involved in the care of CLL patients.
This is a perfect role for a pharmacist. These are largely well patients who've started to respond to their therapies, who need that ongoing monitoring. And we're really well placed to support symptom management of comorbidities, interactions in these long-term patients. And we often provide a lot of consistency in these clinics alongside the consultants.
Catherine is an independent prescriber and has been running her own pharmacist-led CLL clinic for 5 years now.
Yeah, so typically I'll see patients from cycle 3 onwards. So they'll be consented and prescribed their first cycle by a consultant. They'll come back after maybe 4 weeks to check how they're getting on and have that initial first review by a consultant. And then at that point, they'll often be transferred over to the pharmacist-led clinics. And we have protocols and algorithms in place for rapid referral back if there's serious toxicities, comorbidities outside of my area of competence or practice, or where I suspect disease progression.
Tejal told me about her role in supporting patients with CLL.
And then the clinical side of it is supporting the clinicians when they're making their decisions about haematology patients, CLL patients, about what drugs are available, their side effects, how we can manage them if there is a particular drug that is more suited to the patient's disease, but side effects stop it, or there's an interaction with drugs or anything like that. So we get involved with that side of it quite a lot. Speaking to patients is quite a big part of the role. So especially if they're starting new medication, counselling them on when to take it, how often to take it, what they should be looking out for, that sort of thing.
Tejal is also an independent prescriber, and I was interested to hear how she uses the qualification to help CLL patients.
Yeah, so I guess I don't use my prescribing in the traditional sense of holding a clinic and seeing patients specifically in my clinic, but I use it in other ways. If I'm speaking to somebody and they need more of their supportive medication, anti-sickness medicine, then I'm able to prescribe that, or I can support in clinic as well.
As mentioned earlier, people are living longer with CLL. Catherine explained that this is having an impact on the type of patients she sees and the conditions that they're dealing with.
You know, we look after an ageing population in CLL. Median age of diagnosis is somewhere between 70 and 75, and I can regularly do a full clinic list of patients in their 80s, and my oldest patient on my clinic list yesterday was 93. Because people are living longer with cancer and are being on targeted therapies for a lot longer, these patients are then needing knee replacements, hip replacements, having cardiac events, having falls, needing, elective emergency hip replacements, all that kind of thing.
As well as additional comorbidities, it's also important to consider polypharmacy in these patients, as older people are more likely to be taking additional medications. Catherine told me how pharmacists can support patients with this.
Polypharmacy. So I think as a pharmacist, I approach patients in a different way, maybe to the consultants, and I'll support patients with some element of medication review. So sometimes they come in and talk about their pain control and they're confused. And so I'm able to say, right, let's find out what you're taking and help them rationalise their medication a bit, or help them work out timings for their regular paracetamol and then add their opioid in on a PRM basis on top. But, I'll often check in with them on their regular medication history, and I'll see there's multiple laxatives, multiple potentially conflicting pain control, and you can just sort of do a bit of digging and help support that, and obviously then communicate that information through your letters back to the GP.
There are other additional considerations when treating an older patient cohort. For example, Catherine found that the COVID pandemic put a strain on communicating with these patients.
Yeah, so it's challenging. So when COVID came along, we immediately kind of switched over overnight almost to telephone reviews for these patients, because they were shielding. We wanted to keep them safe at home, away from public transport and the hospital, etc. But telephone reviews brings its own challenges in this patient group. Some of them are hard of hearing, which can make telephone reviews challenging. We've not been able as yet to roll out kind of attend anywhere virtual appointments in this clinic. We've definitely not been one of the pilot clinics for that. Lots of our patients don't have smartphones, don't have access to the internet, don't have that kind of digital literacy to interact with those kind of appointments and things. So that's something we've needed to be very mindful of.
And this change in communication could affect patients' adherence to these treatments, as Tejal explains.
Sometimes if patients are well established on a cancer medication, they may not be seen for maybe a month or two at a time. And if it's an oral medication and they've got their supply from us, touching base with them can sometimes help. So if they're not being seen by their clinician for 2 months, maybe calling them every 4 weeks to just say, how are you getting on with your tablets? Have you been taking them? That tends to help.
Consistent contact with these patients can also help clinicians catch any potential adherence concerns earlier.
So if someone says, oh, I've still got, 4 weeks of medication left when they should have run out 2 weeks ago, you kind of then start asking the right questions about how are you taking it? Why do you have a bit more left over than expected?
Catherine has some practical advice for helping patients with their medication adherence.
We support with reminder charts. We speak to family members with consent to help, where people are helping with managing medicines at home. People use all kinds of strategies, self-filled Dorset boxes, support from family members, colour coding, all kinds of things. We help people suggest, text message reminders on their phones, alarms on their phones, or, even ordinary kind of alarms at home, flags. So, having them tablets next to your toothbrush. So if it's 9 o'clock in the morning, 9 o'clock at night, twice a day you brush your teeth, your tablets are next to your toothbrush to have that kind of visual prompt.
Tejal also told me about the importance of patient education on adherence in the context of oral medication regimens.
Yeah, so I think especially like I mentioned, the changing landscape of moving away from just IV chemotherapy and having all these oral agents, sometimes there's a risk that they might not think it's as serious. Again, it's about the awareness that their cancer is different and it's treated in a different way, and that actually having the option to have a tablet-based regimen is quite novel, but it's still equally as important. It needs to be treated the same as being treated as though you were having IV chemotherapy.
It's also important for pharmacists to educate patients on potential drug interactions with their CLL treatments.
Yeah, absolutely. And it's one of my key messages when patients start on treatment, but ongoing throughout treatment. I always say to them, whenever you're prescribed a new medication, make sure you tell the prescriber that you're taking ibrutinib, acalabrutinib, venetoclax. Make sure you tell them that it has drug interactions. If you're buying anything from a community pharmacy, make sure you tell them. And so, huge part of patient education.
Another way pharmacists can support patients is by staying up to date with the latest vaccination information.
We get a lot of questions about appropriateness of vaccinations, and with the change to the shingles vaccine, many of our patients had never ever received the shingles vaccination because Zostavax, the previous vaccine that was used as part of the National Immunisation Programme, was a live vaccine. But last year in 2023, the Shingrix inactivated vaccine was made available in the UK. And so there's been a big push to support our patients who missed out to catch up, who missed out as part of that kind of routine immunisation programme. But making sure patients have had pneumococcal vaccines, they get their flu vaccines, they get their COVID booster vaccines as appropriate. And we get lots of questions from primary care about types and appropriateness of vaccines in this group.
While targeted therapies have revolutionised the care of CLL patients, the treatment pathway can be incredibly complex. Catherine explains how pharmacists can help patients navigate this.
We do a huge amount in terms of helping unpick complex funding queries. So for both CLL and myeloma, the treatment paradigm has changed so much over the last 10 years. I can't tell you what a typical patient or a typical pathway looks like anymore. It depends when you were diagnosed, what treatment you had, how long you were in remission for, whether you received treatment in a clinical trial, which might have been different to what standard practice was at the time, but might be the same as standard practice now, what was funded at the time. And so when every patient relapses or goes on to their next line of therapy in these kind of long-standing conditions, we have to look at each patient as an individual, what they've had, what they're eligible for. And that's a huge role that pharmacists work with the medics on, unpicking that, looking at what NICE approve, what NHS England fund, what we can access, alongside what clinical trial options that we've got for these patients.
While it may seem that the management of CLL is only relevant to those working in hospital pharmacy, Tejal stressed how important it is that pharmacists working in primary care are aware of CLL treatments, particularly in the context of comorbidities.
I think a lot of work needs to be done or can be done in primary care, where once primary care pharmacists feel that they have the knowledge and the confidence to deal with some of the side effects, what they're looking out for. Also, a lot of these patients do have comorbidities, so managing those alongside the CLL, because I'm sure, I don't know, if a patient's got diabetes, we're not really looking after that side of it. We may keep an eye on it, but it's nothing, we're not managing those symptoms. So those patients are being seen or being managed in primary care in one capacity or another. So I think there's scope for sort of more collaborative work for CLL patients between the hospital care and the primary care setting, in managing them more holistically.
Catherine suggested that there was scope for even more collaboration with primary care.
Certainly the supportive medicines, the acyclovir, the cotrimoxazole, things like antiemetics, laxatives, loperamide, that can all be supplied and prescribed by primary care so that it can be done in the right format for the patients, be it large print labels or colour-coded schemes or on a MAR chart or in a compliance aid, or to support with healthcare professionals who help administration of medicines in the community. So it's something that as pharmacists we're well placed to bridge between our medical colleagues and our primary care pharmacy colleagues.
She also stressed the importance of upskilling colleagues across sectors.
We've definitely taken an approach both locally and nationally to that, so to raise awareness amongst colleagues. So going back to BOPA's work, we now have lots of e-learning packages at a whole different range of levels. So we have something called Let's Communicate Cancer, which is really suitable for community pharmacists, and that's all about raising awareness of red flag symptoms and how to signpost patients who might have spotted an early diagnosis of something.
And finally, Tejal highlighted the importance of asking for help when it comes to personal and team development.
I've always said this, pharmacy is a really small world, so I think just reaching out to another hospital, another pharmacist and saying, hey, would you mind having a 5-minute chat with me about something? And most people are more than happy to help. Lots of hospitals are willing to share their resources if they're doing something new and it's worked for them. I know the Thames Valley Cancer Alliance, and I'm sure East of England do as well, have regular sort of meetings with pharmacists, with MDTs, to say, okay, this particular hospital, our patch is having a really rough time of staffing, for example, what are other places doing? And you can just feed ideas off of each other. So there are forums to share information, share best practice. And I think it's really good to be part of that.
I wanted to hear from Anthea about the involvement of pharmacists in her care, and it was clear that there are variations between trusts.
I would say I've had one follow-up consultation with a pharmacist, and that was probably about 6 months ago, because the system locally has been very much based on phone consultations, and that hasn't changed, since things have opened up from COVID, and I think it's regrettable.
Anthea was impressed with the pharmacist's input.
So I'd had speciality doctors, and I would say the pharmacist was better, because there were times I was told everything was stable when it wasn't. When you asked for actual results, you found that your haemoglobin had dropped by 10%. The pharmacist took, I would say, more time and more care.
Anthea is a trustee of the CLL Support Association, and she thinks that another way healthcare professionals can support patients is by being mindful of emotional support needs.
I think health professionals don't always realise what a burden active monitoring can be. Living with a cancer diagnosis and not knowing if or when you're going to need treatment. People struggle with that. As a patient support charity, I think this is where I think you pick up on what really needs to be done. And we've now got a very active support programme. We've got something called Support Act, which is a programme based on something called acceptance and commitment treatment, which is a development from CBT. And we've got a behavioural therapist who's developed this program. But the other thing we've added is CLL support funds one-to-one sessions with the therapist via Zoom for people who really need it. And also drop-in group sessions going through the Support Act programme.
So hopefully, if you're a pharmacist working in either primary or secondary care, you found this episode informative and have a better idea of how you can support CLL patients. I want to thank Anthea for guiding us through her experience, and of course also thank you to our experts Tejal and Catherine. We'll include links to the CLL Support Association and any other relevant resources in the show notes. And finally, thanks again to Beijing for supporting this learning episode of the PJ Pod. That's it from us. Please do follow us on whatever podcast platform you use and let us know what you thought of this episode or ideas for future ones on social media using the hashtag PJPod. Until next time, goodbye.